I would now like to introduce and hand over to our chair for the event, Alison Cox. Alison is the Director for Policy and Research at the Global Climate and Health Alliance. The GCHA works to tackle global climate change and, through this, to protect and promote public health. GCHA's alliance membership is made up of health organizations from around the world who are united by a shared vision of an equitable, sustainable future, wherein health impacts of climate change are minimized and the health co-benefits of climate mitigation are maximized. Prior to her work at GCHA, Alison was the Prevention Director at Cancer Research UK, where she led successful campaigns for restrictions on tobacco and junk food marketing and built an international program to support tobacco control advocacy in LMICs. Alison has also led strategy development and direct advocacy for global public health alliances, including for the Framework Convention Alliance and Non-Communicable Disease Alliance. Welcome, Alison.
Thank you very much, Freddie. I'm delighted that RSPH has decided to start the new year with this webinar on reimagining public health in the aftermath of the pandemic. I'm very pleased to have the opportunity to chair the session today. I'm not sure if we're quite at the aftermath stage yet, but as the pandemic unfolded, the relationship between the health of the public and the health of the economy has never been so salient. And inequalities in COVID experience and impact and outcomes was felt geographically, socioeconomically, by race and ethnicity, and they've been starkly revealed how the wider determinants affect our health. All of this has been front page news over the last couple of years, and it's been the issue of the day. And yet there's been a cut of around 24% in real terms per capita to the public health grant here in the UK, or here in England since 2015-16, which equates to around £1 billion reduction. And yesterday, the government's Levelling Up white paper yet restated an existing public health target of increasing healthy life expectancy by 5 years by 2035, but gives little detail on what will be done to make this achievable. So in my view, we desperately need a campaign for public health and for the diverse voices working across the health risk factors, disease prevention, health inequalities and public health services to develop a compelling new vision and capture the public's support. And as Jyotsna will say in her presentation, if not now, then when? And the fact so many people have subscribed for this session today suggests we're not alone in thinking this. So this webinar has been somewhat prompted by the publication of Chris Thomas's book, The 5 Health Frontiers, that addresses challenges for public health in the NHS, in social care, in the broader socioeconomic environment, in this country and globally, from the pandemic to the climate crisis. And our speakers today are going to bring both a UK and a global perspective. So there's a lot to get through, and I very much hope this will be the start of a series of such conversations that the RSPH and others convene to try to build the momentum in building a new vision for public health. So just a quick run through the agenda. Our eminent first speaker today is Professor David Nabarro, who is the WHO DG's Special Envoy on COVID-19 and could not be better qualified to address the topic of this webinar. David can't stay for the full webinar, so we will be taking questions for him immediately after his presentation. Chris Thomas will then pick out some of the key themes from his new book, The 5 Health Frontiers. And we're very pleased to also welcome Jonathan Ashworth, the Labour Shadow Secretary for Work and Pensions, previously Shadow Secretary for Health and Social Care, who's going to bring his knowledge and experience across those two portfolios together, speaking on the intersection between health, work and poverty. I'm then going to offer a very brief introduction to why the climate crisis is the biggest health challenge the world faces. And then Jyotsna Vora, Director of Policy and Public Affairs, RSPH, will pull together some themes around public health today and the gap between this and a vision for the future. As this is a 2-hour webinar, I will suggest an odd moment for getting up and stretching, but there'll be no other intermission. So without further ado, I'm going to introduce our first speaker. Professor David Nabarro has had an extraordinary career as a leader in global health, leading on global responses to disease outbreaks and health emergencies. He led the Rollback Malaria Project, was Special Envoy on avian and pandemic flu, and led on the response to the Ebola outbreak. And in March 2020, as I said, he was appointed as Special Envoy to the Director General of the WHO on COVID-19. He's worked across a broad range of the most critical global public health issues, from food systems to climate change and nature-based solutions. He's also the co-director and chair of Global Health at Imperial College London's Institute of Global Health Innovation, as well as the strategic director of the Swiss-based social enterprise 4SD, which trains and mentors leaders for sustainable development. And he's also the co-chair of the World Innovation Summit. So I'll pass over to David, who's going to speak on the global public health perspective, where we are now and what needs to change in relation to the pandemic. David, over to you.
Alison, that was a lovely introduction. You know, when giving a talk, you never quite know what the introduction's going to be like. And especially if, like me, you've moved around into quite a lot of different kinds of work. But you did it super good because you showed that actually in my life, things do vaguely fit together. And I'm the kind of person who got into health and then got into public health and then got into community public health and then got into all the things that influence health. And it's been a most wonderful discovery. And I wanted to come to the Royal Society of Public Health because I've learned so much through COVID that's confirmed what I learned through other infectious disease issues. And I wanted to share it, especially as I know that you are working on a campaign for the future of public health. And so what better place to bring my reflections. So thank you. And it's a good chance also to thank you all at the Society for honouring me the other day with an award for an outstanding contribution to international public health. It's great to be back with you, with this sitting behind me and making me feel very much part of the organization. It's wonderful. So here's how I'm going to work. I'm going to present 5 learnings from the pandemic, and then I'm going to talk about the implications of those learnings for the future of public health. And I hope that I will be sufficiently broad that you will see that what I say applies to most parts of the world. And I hope, therefore, that those joining from parts other than the UK or Europe will find it interesting. I'm going to try to put my email address in the chat. And if anybody wants to follow up, please do so. I'll do that towards the end. So here I go. Yeah. My first slide, it reflects a first learning from the pandemic. Now, I had a slide before this called Learnings from the Pandemic, and I don't think I can find it. Let me just see. No. Okay. So I've got to try to go back, and I need to do that quickly. Here we are. I can see now. Thank you. Good. Thank you. There we go. Thank you. I'm starting by focusing on my 5 learnings from the pandemic. The virus continues to circulate. It impacts on all sectors. Decisions about what to do on the virus require explicit trade-offs. Collective responses are powerful and are needed, and public health is vital for societies and economies. I've shortened these learnings down really, really low, and I hope that they're sufficiently odd, perhaps, when you look at them, for you to be thinking, what does he mean? The virus continues to circulate is me making the point that this pandemic does not look as though it's going to disappear. The virus is going to stay. It's going to continue to affect people unequally, and it's going to affect people with varying intensity at different times of year. And we need to not only know where the virus is and what it's doing, how it's behaving, but we also need to remember this virus doesn't just have an impact on people that is dealt with through the health sector. It impacts on sectors to do with employment, to do with food, to do with travel, to do with security. It impacts on sectors linked to education and well-being. And in fact, as you go more and more into detail, you find that most sectors of government are affected by it. And because it's necessary to keep economies moving, whilst at the same time coping with a virus that kills a proportion of the population it infects, but it can be a very small proportion. It's inevitable that there are going to be trade-offs as decisions are made, and being able to handle those trade-offs is a key part of public health. It's not good enough for the public health person to say, I shall advocate an activity which maximizes health outcomes because that's my job. The public health professional has to be able to present options for what might happen if different degrees of action were taken in terms of trade-offs. And public health works best if the responses are done together. Collective responses are much more powerful than fragmented responses. And then without public health, societies and economies don't thrive, they wither. And so actually public health is a vital underpinning for modern societies and modern economies. And I'm going to build out of these and just make a point that these are absolutely critical elements of any rethinking of public health following the pandemic. If you feel that I'm just losing the plot, just stop me, please. So I start by saying the virus continues to circulate. And this graph, which is the compilation of the numbers of cases of COVID-19 reported to the World Health Organization each day on the y-axis left-hand side, and then the number of people dying that with a linkage to COVID on the right side y-axis, and then the months since the start of the pandemic on the x-axis. The shaded area is the area underneath the graph of case numbers. The continuous black line is the dot showing deaths in the past 24 hours at different times. What's really strange about this graph is that the shaded pattern is now really quite low in the months leading up to December 2021, and then suddenly streaks up with a huge surge in the period December, January, and into February. It didn't look like this 2 months ago. It's a big, big shift. The different colors in the shaded area distinguish between cases reported from the Americas, from Europe, from Africa, from the Western Pacific, from the Middle East, and from Southeast Asia. If you want to look in detail, it'll tell you when was it that there was a big spike of cases coming from Southeast Asia, that was India, and so on. But I don't want you to feel that you should dig into this. If anybody wants to get disaggregated data, contact me and I can get them to you. I'm wanting to show you three things. First, there are over 3,300,000 confirmed cases reported to WHO in the last 24 hours, 3.3 million. That is enormously more than the number of cases that were being reported, for example, in a high time in September 2021. We were at something like 600,000 or 700,000 then. I mean, we've gone up fivefold in the numbers of cases in the recent weeks. Secondly, I want you to see that although there's been a huge increase in the numbers of cases in the last 2 months, the numbers of deaths have not gone out quite so sharply, but they have gone up. There is an uptick in the death numbers running from January through to February now, and that is being treated as very significant. This is a definite rise, gone up from about 5,500 per 24 hours to just over 10,000 per 24 hours in the space of 3 weeks. And then the third thing I want to stress to you is just that if you can possibly just track through the green shading, there's quite a lot of green under this curve here. And that's showing that there has been a lot of case reporting from Europe. And the green and yellow means Europe and Americas. Most of this disease in the period since it was discovered has been present in Europe and the Americas. So there's no way that anybody can say this is a pandemic that's still running. It is near the end, sorry. It is very much still running, and there are lots of surges, and predicting the surges is really difficult. Now, the virus impacts on all sectors. So we have a health problem, but it has economic and societal consequences for individuals and for groups of people, whether they're in households or in institutions or in local authorities. They're all being affected. So it has impacts on health and education systems, on food systems and people's nutrition, on supply chains and logistics. And that's just the beginning. And to deal with something that impacts on all sectors is that it's necessary to have a response that involves all sectors and the whole of society. And it needs to be really well coordinated and not just coming from one department or one ministry. And it's going to depend on integrated, fit for purpose, public health capacities, local level, that span all sectors. So I'm trying to make the point that this is truly a multi-sectoral issue, and it's not enough just to say the response should primarily be with the health sector. And I'm going to say that public health in this pandemic is an approach to health that is ready to look at all sectors. Number 2 point. Decisions that are made in relation to this pandemic require explicit trade-offs. It's not satisfactory to think in terms of there being a kind of explicit instruction coming from on top that everybody's going to follow to the letter. The nature of this challenge is that the decisions have to be adapted to local context. And that means thinking through risks and benefits of each action and then making trade-offs to make the choices. And we find that means that it's really important to understand as much as possible about spread and risk. The spread is dynamic. The virus exists in swirls, in spikes, and in surges. And a spike can turn into a surge very rapidly, and that can lead to quite acute challenges. Now, this swirling, spiking, and surging is very disturbing when it really affects populations, and it reveals gaps in systems, particularly systems that are designed to protect poorer people. And we find that when COVID is active, either the COVID itself or the containment measures have greatest impact on poor and disadvantaged people. There's got to be public health measures to encourage containment, interrupting transmission, detecting cases, establishing contact tracing, isolation, shielding of those in greatest need, being able to deal with big surges and to break them down through movement restrictions and isolation. It's basic public health. It's no good trying to do it without it, but public health work has always got to be risk-based and not based on any kind of ideology. And all this has to be done amidst a terrible false dichotomy that we've been living with the last 2 years, that it's all about a choice between restriction and liberty. No. Some restriction may be necessary to guarantee liberty, and that's what I think most of us believe. But to present it as a choice is wrong. So these 6 points are the basis for thinking about trade-offs.
David, just to give you a warning, you're on your 15 minutes.
Okay. Collective is more powerful than fragmented. Shared values, agreed purpose, common narrative, functioning networks built on public health principles and tailored to local context. I think that works that is a way of working, and one that we very much want to get right. I'm sorry, this is not going the right way. Okay, so I'm messed up on my slides. I was trying to go backwards. So I'm not sure if somebody could just click the slides backwards, that'd be really helpful. If not, no problem. No, it's not working. Okay. All right, so I'll finish now. I want to encourage that there is a recognition of the vital importance of public health in the efforts to control COVID-19. And at the heart of this is a set of leadership principles that start from an acceptance that all of humanity, next one, going back, all of humanity, thank you, is hurting. especially people with less power. And that the only way to deal with this virus is to display humility, because so much is not known. We should be very careful saying we definitely think something is going to happen. We have no basis on which to say it. We should adopt a holistic and systems approach when trying to respond. We should, when leading, be honest in words and actions, and making dishonest promises or stretching the evidence to make a case about a particular therapy working is wrong. And it's important when we're advising on decision making to be hopeful when it is justified. And then I'd like to just go to my next slide, which is to say, if you could work it from where you are, thank you. The one with, if we're going to be able to work effectively, taking account of these kinds of considerations for getting an effective public health response after COVID, perhaps when we've got the next pandemic disease, there's a set of leadership skills called the skills of systems leadership that are the key. And I just say them quickly. First, being able to hold competing perspectives simultaneously and to be able to work within paradox. Second, to recognize that the whole system has to be seen differently to its separate parts, and to be comfortable with working with the big system and the little pieces. Thirdly, having the skills to be able to feed into the pace, rhythm, and readiness of change, especially when trying to encourage people to live and work differently. Fourth, recognize that all systems have to be seen in relationship to their environments because they adapt to their environments. So there's no one size fits all. And fifth, never assume that how people are where they are. Always go and meet them right where they really are. Things work much better if you don't make these assumptions. I believe that these principles of systems leadership are based on the 5 H's I had in my previous slide, and these essential qualities are going to be absolutely central to the future of public health. It is not a linear discipline. It's a discipline that requires working with multiple interconnected systems full of human beings, and it needs a living systems approach, which is doable, and it's actually done in many parts of Britain and Europe. It's not the prevailing leadership practice that is often to be found right at the top, where the search is constantly for quick, crisp, linear solutions that will solve the problem, and taken to scale, they will transform the system. In my experience, that's not the best way for public health. Thank you very much indeed, Alison. Sorry for the overrun.
Not at all. Thank you so much, David. Really interesting how you've pulled out, the very complex nature of the pandemic and the multi-sectoral approach to trying to deal with health, the complex systems issues involved in health, and the health crisis we're facing. Just looking at the Q&A, just to quickly ask you, there were 1 or 2 questions for clarification around the figures. Basically, people are asking, what's the sort of level of standardization across the way the statistics are collected in different countries and regions? How confident can we be that we're comparing like statistics? Is there anything you want to say to that before we move on to some of the more systems-based questions?
In the WHO, the organization is dependent on what it receives from countries. There are processes for standardization and for quality control. but it is the country that's in charge, not the WHO. So if it turns out that the data coming through from a country don't make sense based on what we hear from individuals at the country level, then there's scope for a dialogue, and there may be scope for upgrading the numbers. But we don't, WHO does not have the kind of forensic ability to go into a place and sort of say, we're going to take over and count the numbers. It doesn't work like that. So there are questions. But secondly, in different situations, there's always going to be variations in availability of tests. There may be variations in the way in which the tests are done. And so the real thing that's happening at the moment is there's a huge underestimate in numbers because there's not enough PCR tests to go round. And there's even a major shortage of lateral flow tests. And so the information, whether it's based on PCR or based on lateral flow, is incomplete, and it's more incomplete now with Omicron than it has been. So as well as questions about whether the correct information is being provided, there's also questions about whether there is just systematic underestimation because of overload of facilities. And we do what we can to try to clean it up, but we know that we're never getting it absolutely right.
Fantastic. To take a more sort of thematic question, somebody here, Samar's asked, will COVID-19 bring about a change in the definition of public health, given the various challenges that failed the rapid response worldwide? So, I mean, you've talked yourself about the complex systems nature of the pandemic and for the need for a multi-sectoral approach. Is there anything you'd like to say about how we define public health?
When we started work in February, actually, 2020, we had some very early information from China suggesting that the four things that work best are firstly, community-based health watch, which would be having a volunteer and then say 100 households, and the volunteer would keep a check on people's health status and various other things in their communities. Then we would have the public health services who would deal with the spikes and the surges and wearing white coats and go in and do stuff. Then there's the hospital care, and then there is what the rest of government does. So these community-based health watches, they would be the people who would help to make sure that people wore masks, and that people were maintaining physical distance and various other things like that. The public health surge teams would deal with the big outbreaks and doing movement restrictions where necessary. The teams in the hospitals would try to deal with COVID transmission in the hospital, keeping one part of the hospital COVID clean and the other part perhaps COVID dirty. And then the whole of society part will be dealing with food and dealing with transport. The part that so many countries did well and are still doing well is trying to improve hospital services. Some countries have got their public health surge management quite well developed, but very few countries did the health watch idea. And yet that's the basis of an awful lot of healthcare in poorer countries in Africa and in Asia. And they did it and they found it quite useful. So the one thing that we would say is that public health in the future perhaps may need to go back to having one person per 100 families or less or more with a responsibility to keep in contact with them and to provide some kind of cover, not doing clinical work, but just simply finding people who are unwell, finding people who need support and so on. And I do think that close coverage, public health capacity is really helpful when dealing with these kinds of infectious diseases, where the issue for individuals can be quite complex. And I mean, many colleagues have told me that experiments have been tried. And I mean, the only other thing I want to say is that if I were a chief medical officer now, I would be doing everything possible to elevate the function of the district public health professional and those who work alongside them and their capacity to create integrated, locally functioning services. For me, that is the part also that's gone missing. So I think it'd be a case of putting back in things that might have gone missing. Over.
Thank you so much, David. I appreciate that you've got to get off, so I'm going to leave it there in terms of questions to you, but thank you in particular for, highlighting both the need for investment and understanding of the needs at the community and local level, as well as really drawing out those issues about the complexity of the global leadership needed and the political leadership to deal with the multi-sectoral and complex systems nature of the pandemic. Yeah. So really, really helpful perspectives. Is there any last words you want to say before we let you go?
So grateful to you, Alison. Really very, very important. Virus is the problem and people are the solution. So therefore, all actions that are prescribed should have at their heart, how can we keep people as partners in the response? Any activity that is designed to perhaps alienate people should be applied with care, because it's not a good idea in my view. Myself and colleagues are really nervous about vaccine mandates or even mask mandates. I think it's reasonable in situations of very high exposure to require that masks be worn in an occupational sense. But I think one has to be really careful about prosecuting people on things like mask wearing or on things like vaccine refusal, because we're all the time trying to scoop people in and have them being comfortable with being partners in the response. I think that means that, then I think that my vision of public health is one that works across boundaries. If you've got a very siloed government or international organization, especially with budgets down the different silos, that will make cross-working really difficult. So I am rather committed to being transversalist in my way of working. And I think public health has to be a transversal discipline. I think for a country with quite high incidence of COVID and not lack of clarity on how much long COVID there is around the place, to be dramatically encouraging people not to take precautions like mask wearing and physical distancing or hygiene or those other things, and just say, well, do what you feel you need to do. To do that when you've still got 80 or 90,000 new cases a day, and probably more, seems quite strange. In WHO, the line is, if you've got high coverage, if you've got high numbers, you need lots of people vaccinated to shield them, and you need mask wearing and physical distancing and all the rest. And they're a combination. Don't have vaccines without the public health and safety measures. So we would say how it is a surprise that in the UK, the measures are being discouraged, and we're interested to see that quite a lot of populations are reported to be continuing with them. So there's just some last comments on what Christopher Turner, Glenn Laverack, and Flav Kupka asked. Thank you very much indeed, Alison.
Oh no, thank you, David. And really good final messages there about putting people at the centre of public health. I'm sure that's a theme that's going to come across in some of our other contributions. And also for that transversal approach to public health. This isn't just about health, it's about so much else and so many sectors working together. So really excellent way to start off this session. Thank you. So do stay with us as long as you can, but thank you again for joining us today.
Thanks for having me. Great.
Thank you. So our next speaker is Chris Thomas. He's a health writer, commentator, and author of The 5 Health Frontiers, which you can see on the screen just now, which has been published by Pluto Press. He's also a principal fellow at the Institute of Public Policy Research, IPPR, and heads their flagship health and care programme. Outside of his IPPR work, he regularly contributes to Tribune magazine and has with bylines in The Independent, the Health Service Journal, The Times, and beyond. So he's going to pull out some key themes from his book, which is about going beyond a defensive approach to health services. So I'm going to hand over to Chris and look forward to hearing your thoughts. Chris.
Thanks, Alison. And it's brilliant to be speaking to so many people, and a huge congratulations to the RSPH on putting together this forum. I think when I was writing the book, when I was reflecting on what comes next after COVID, or in light of, we shouldn't say after, but one of the things that I constantly reflected on was the need for more of these forums about discussion of what the future looks like. So it's brilliant that we have one here today, and with so many people tuning in and engaged as well. It's really brilliant. As Alison says, I'm speaking today from the perspective of the 5 Health Frontiers. It's a copy there so people know what it looks like in real life. And I suppose what I wanted to take us through were some ideas that come out through that book for the long term of what public health looks like. So what do we do now? We've seen what we've experienced, we've learned lessons from COVID-19. What's the long-term plan now for public health? And I'm going to start by talking here in the same place that I start the book, and that's maybe slightly surprisingly with some remarks on George Orwell, or Eric Blair, as he was known in February 1928 in a cold winter in Paris. And George Orwell was one of many writers drawn to France. His contemporaries would have included Gertrude Stein, would have included Ernest Hemingway, Jean Rhys, but his experience was very different. So whereas those writers were kind of known for the hedonistic experience of Paris, the champagne, the cafes, George Orwell was struck down by a respiratory illness. We don't know quite what it was. We think probably pneumonia, but some parallels there with the things that we've experienced over the last 2 years. And the illness Orwell experienced took him to l'Hôpital Cochin, and that's a hospital in Paris that still stands today, but with a much better reputation, because at the time, George Orwell would experience, in the first instance, a 20-minute interrogation before even admitted, an interrogation he was subjected to with a temperature well over fever pitch. He was put into the hospital uniform of a gown and slippers, marched through the courtyard, again with a fever, in a cold February evening in that scant clothing, and found himself in a room with hospital beds packed together 6 inches apart. No TV, of course, but the sight of other people undergoing hugely unpleasant bodily operations, a smell that he describes in his writing about the incident as a mixture of feces and sweetness. So an awful experience. And the reason this is interesting is because Orwell reflects on it as the experience of how the poor die. So for Orwell, this was the kind of experience that showed the duality of health in the 1920s, in this case France, but actually across a lot of Western Europe. For the rich, the experience would have been very different. It would have been a private room, or it would have been much more likely home care, so bringing doctors to see you in your residence. And it was this kind of writing, this kind of experience that led to the groundswell in the 1940s. And in fact, Orwell publishes this experience in the 1940s that underpinned the kind of appetite for universal healthcare, so the creation of the NHS. And my argument is, in many ways, the huge achievement of the origin of the NHS has led us, or some, to think that much of the work on equality has been achieved. Free at the point of delivery based on need in terms of healthcare has taken us a long way. And you saw that narrative, I think, emerge in the COVID-19 pandemic. It was very interesting to me that we had articles in outlets as wide as The Guardian, The Evening Standard, and The Daily Express in this country, talking about how COVID-19 was a great equalizer. We had viral videos of Madonna in a marble bathtub declaring the same, Arnold Schwarzenegger smoking a cigar in a hot tub in California saying the same, that in the face of a health threat, we were all equal. But of course, the hard data proved otherwise. And in fact, we saw that based on occupation, based on deprivation, based on race, based on all the factors that surely we would have predicted, that actually the risk of COVID-19, infection, mortality of long COVID, that all those things ran across those lines. So what we surely learn is that the work of health, the policy work, is not complete. There's still much more that needs to be done to secure good health for all and to make sure that that is justly distributed to everyone. There's still a lot of work to do. But it strikes me that the kind of campaigns, if we're thinking, do we have the infrastructure to secure that change? The kind of campaigns that we have are not brilliantly optimized for that. If we look at what draws people in their tens and hundreds of thousands to march through Westminster, what kind of the major campaigns are in health at the moment, they tend to be framed around save our NHS. They tend to be a rearguard action against privatization. Now, I think a public healthcare system is vitally important, but it's interesting that those campaigns, compared to the movements like the Green New Deal or the New Economy, are more small c conservative. They're about maintaining the status quo, save the NHS, rather than expanding a new vision for what the realities of health and public health look like in the future. So my book is about going beyond that and lays out 5 areas where we can start to think about what a more future-focused vision might look like. How can we think about building something in public health akin to what we've seen in something as ambitious and as societally important as Green New Deal, with all the impact that's been having both here and across the Atlantic. So I'm just going to finish my short remarks with a short run through what those 5 ideas are. The first is the NHS. And I think it's very important that we think about what the revitalization of the NHS looks like. I point out that for too long, we've run the NHS at the top of its game, top of its capacity for the last 40 years, when we need to run it at the top of its game. So universal healthcare, that's a device for universalizing the best, vitally important as a foundation of what we talk about. But there are opportunities to go further. So the second point is an expansion. I think Jonathan will talk about this more, but an expansion of the principle free at the point of delivery based on need, that Bevanite principle that's proved so popular, so enduring, from the medical to social policy. So why is it that we don't have that basis applied to things that we know from the evidence are really good reasons that people get sick and that inequalities exist? Why don't we have that delivery mechanism for housing, education, nutrition, money, income, skills? So for me, a universal public health offer that meets need with provision is a vital expansion of the work that Bevan started in the 1940s. Of course, we need to understand why people experience that need in the first place. And I think to that, we need to turn to the economy. We need to think about why it is that our economic model allows unhealthy activities, whether that's products, whether that's bad employment terms, bad landlords, why that's allowed to happen without really any cost. Why is it that those activities can never be profitable? I think we need to think about what we measure. So GDP, a figure that we know from climate movements is very problematic, but from a health perspective, we can see not only counts the activities that make us sick, so say the production of tobacco, cigarettes, but the activities that then result from that, the hospital care that we go through. So we need to understand that our economic models and measures are sometimes incentivizing us to disregard health, to not regulate, to not intervene. And I think put in place a new measure, a new target, something that puts health at the heart of society's mission, what I call a public health net zero, a target whereby we aim for no health cost from economic activity. I think we need to incorporate social care, the fourth frontier. For many, this is where there's been more vibrancy in terms of campaign work, the National Care Service. But for me, that's about universality, which is great, and free care, which is also great, but not quite about quality yet. So I think bringing personalised care and the views of people who draw on social care into that vision of what social care delivery looks like, absolutely vital going forward. And last, a word on sustainability. All of this is in light of and in the aftermath of what we've experienced in terms of COVID-19. But we need to recognise that COVID-19 isn't once in a lifetime. It's not a shock event. It will repeat without intervention. And I think the crucial thing is that it doesn't repeat in terms of waiting for a crisis just to happen. So the last frontier is all about making sure that we have the policy infrastructure, whether that's a Future Generations Act, whether that's looking at how UK finance works, that is cognizant of the fact that the risk factors that are driving climate emergency are undermining health vulnerability, and we need ideas on that and ways to act. So the book, in terms of its ambition, is not really designed to be about explaining a consensus that currently exists. It's all about opening up debate and seeing whether more ambitious thinking can get a foothold, more ambitious policy thinking. And so that's why I'm thrilled to share some of those ideas today. Really excited about the question and answers, and a big encouragement that if any of those capture the imagination, do keep in contact afterwards, because I think talking about these and thinking about after the crisis that we've just, that we're still experiencing, how do we move forward? That's the vital work that we need to engage in. Alison, I'll pass back to you, I think, from there, but hopefully that's helpful.
That's really helpful, Chris. Thank you. And it's been really interesting. Reading your book's been a great read, and I'd recommend it to anybody. There's been some chat in the chat boxes, people talking about social care as an issue. I was just wondered if you just want to elaborate a little bit on some of your chapter on social care and specific proposals around that. Yeah,
absolutely. So I think the starting point is looking at what are the kind of big consensus progressive proposals that we see. And I think we see that broadly, if we strip them down to their principles, that making sure that social care is available to everyone, because there's so much unmet need in social care, is really important. And making sure that people aren't barred by price. So that principle of free at the point of delivery based on need that we see in the NHS, expanding that across, and I think that's vital as well. I think the problem is that beyond that, the quality of social care that we have in England particularly is so low that what we need to be very careful of is that we're not doing something, if we were thinking about mental health in the asylum model, that's just making the asylums accessible and free, because actually we know that just wasn't the right way to approach that type of care. That was actually something designed to, to take away inconvenience from people that weren't being cared for. So I think we also need to consider tearing down the system of care that we have and the types of care that we provide, the 15-minute on-the-fly care appointments that we know are still commissioned in local authorities. The fact that social care homes in this country often resemble more the warehouse than they do anything that would make someone's life flourishing by any stretch of the imagination. There are lots of ways that we can do that. There are lots of models out there that are really exciting. Bertzog in the Netherlands, Hoogway, the dementia villages in the Netherlands, that prove that actually, there are some fantastic ways to do care that aren't that much more expensive. And then kind of once the upward investment to bring those models in, once we break the path dependency that we have at the moment, those models don't cost more money, but they do have much better outcomes and allow much more personalization. I think the other thing that the book talks about is the need to bring a lot more of the care that we have and the opportunities that it provides towards where people live and the communities that they live in. So there's huge potential, to my mind, to bring more care delivery into, if not people's homes, into people's communities, and to at the same time give them much more control over what that care looks like. And combining that with a universal delivery model strikes me as the best next step that we can take on social care. So free universal, yes, but let's also think about how it can be brilliant.
Brilliant. Thank you very much, Chris. So I encourage everybody to be putting questions into the Q&A box, so for when we come back to the Q&A session at the end of the speakers. And also, thank you to those of you who are providing some commentary in the chat box as well. Your thoughts there are also valuable for making the richness of this conversation. So our next speaker is Jonathan Ashworth, who has been the Labour MP for Leicester South since May 2011. In 2021, in November, Jonathan was appointed to be the Shadow Secretary for Work and Pensions, having previously been Labour's longest running Shadow Secretary of State for Health and Social Care. He's also served as a Shadow Minister without portfolio and Shadow Cabinet Office Minister, and is a Policy Fellow at the Centre for Science and Policy at the University of Cambridge. Before being an MP, Jonathan worked in the Treasury as a Special Advisor to Gordon Brown when he was Chancellor, and continued to work for Gordon Brown when he became Prime Minister. So Jonathan is going to focus on the intersection between health and work and poverty, and how that feeds into health securities. And he's also going to, I hope, talk about the broader role policymaking can play. So Jonathan, over to you.
Well, thank you very much. And thank you for that introduction. It was a little bit like This Is Your Life, and I'd forgotten some of the things I'd done over the years, but it's a pleasure to be here. And can I start by thanking the Royal Society and your members for your leadership, your professionalism, and particularly those who have joined the call who work in public health, not just across the United Kingdom, but across the world. I can see from the chat box for your extraordinary dedication and contribution throughout this pandemic these last 2 years. It's obviously an immense pleasure to speak on the platform with David, who I follow closely, who has been a wise voice throughout these past 2 years, and who I always find inspirational. But it's also a pleasure to speak on a platform with Chris Thomas from IPPR. Chris, I believe, in my view, is one of the most brilliant thinkers in health policy, and I think his book, which he has just published, will be absolutely central to the debate about how we reform and rebuild public health and social care in the years ahead. And in that respect, his book is immensely timely. And I think Chris's book, and indeed the work of the Royal Society over many years, is about a central truth about health. And it's a truth that drove me when I served as Labour's Shadow Health Secretary for 5 years, and continues to be at the heart of my thinking now that I'm Labour's Shadow Work and Pension Secretary. And that central truth is that all have the right to good health and well-being, that good health is fundamental to spreading opportunity where everyone can flourish, and that good health across the population is the foundation of a secure and prosperous society. And that good health is created by the conditions in which we live and in which we work. Now, here in the United Kingdom, the government published yesterday a white paper, a set of proposals on so-called levelling up. But I just say to colleagues that there can be no levelling up unless inequities in health outcomes are tackled. It was a previous Labour Health Secretary, Frank Dobson, who used to say, there is no more serious inequality than knowing you'll die sooner because you're badly off. And the pandemic has revealed the devastating truth of that insight here in the United Kingdom. COVID spread easily in public-facing workplaces, in crowded factories, in overcrowded housing. It spread where low-paid workers had no option but to carry on working even when ill because of lack of sick pay and recompense. And it is striking that care homes where staff had access to sick pay generally suffered fewer outbreaks. The more deprived suffered worse from COVID, and reported long COVID is higher in more deprived areas. But what's depressing is that none of this comes as a surprise to any of us who care about public health. Just as we went into the crisis, Michael Marmot's research showed how 10 years of austerity with poor housing, food insecurity, lack of green space, insecure incomes, had given us deteriorating population health, increasing health inequality, and falling life expectancy. The reality is, the more deprived you are, the fewer years you can expect to live and enjoy in good health. The poorer you are, the more likely you are to suffer from mental health problems, from diabetes, from cancer, heart disease, COPD, obesity, and health impacts on your employment opportunities too. And what that meant in these last 2 years was that it was our poorest communities who paid for years of that austerity, years of those cuts, sadly with their lives and their livelihoods. I always say this, poverty makes you ill, and illness often traps you in poverty. But while poverty is not self-correcting, it need not be inevitable. Now, the last Labour government lifted 1 million children out of poverty. We rolled out Sure Start centres in communities, which the IFS has shown help prevent thousands of hospital admissions for children every year. So you can make a difference. But under this government today in the United Kingdom, more than a third of children live in poverty. Over 500,000 children live in destitution, the severest form of poverty. Around 500,000 children do not have a bed to sleep in. In my view, this shames our society. And we know poverty impacts a child's development, learning, health outcomes, and their future opportunity. So levelling up should surely mean bringing the life chances that the most fortunate enjoy to the grasp of all, not just those privileged few. But instead of putting in place a child poverty strategy, we have ministers cutting universal credit by £20 a week, by £20, and even after changes to the taper rate, 3.2 million households are still worse off. Heating bills are rocketing, and even after today's announcement on an energy bill rebate, prices rising in the shops and taxes increasing, families will still be worse off by around £1,000 a year. Families will still be forced to make the most impossible choices between heating and eating. And the Bank of England today is predicting inflation will peak at more than 7%, while benefits are uprated by 3%, effectively a 4% cut. This is willful impoverishment. And what's been announced today by the Chancellor fails to protect those most at risk of hardship. It will see poorer people get further into debt. And to rub salt into the wounds, the Levelling Up white paper yesterday mentions the Medici family of Renaissance Italy 7 times and child poverty 0. Now, in the past, employment was the answer. But today, in an economy characterized by low pay, insecure, temporary work, 68% of people in poverty are in working households. That's a record level. Many of those were the ones queuing up at food banks, even though they have jobs. And I see that here in my Leicester constituency. The type of work you do, the conditions and its setting impact on your health outcomes. So when we talk about learning to live with COVID, that cannot mean ignoring COVID. It must mean decent sick pay for all. It must mean health and safety in the workplace taken seriously again. It must mean ventilation support for businesses, for public spaces, for school, because better ventilation has time and again been proven to reduce transmission of COVID. But not only does it stop, but does it help reduce COVID, better ventilation brings other health benefits as well. Now, every month, because of what's happening in our economy, 40,000 people almost are having to leave the labour market due to long-term illness. There are over 2.3 million people who are economically inactive because of long-term ill health. That's the highest since 2005. Compared to the start of last summer, that's an increase of 9%. But instead of a plan to support people to stay in work, to tackle these drivers of ill health and to understand what's really going on, all ministers are offering is a tightening of the sanctions regime for those claiming universal credit. So poverty and work impacts on health outcomes. And that's the lesson I want to bring to this role in my new role as a shadow work and pension secretary. And when I was in health, I was always very much influenced, and I remain influenced by the work of Geoffrey Rose. And there'll be many public health experts on here who will appreciate Geoffrey Rose's work with far deeper understanding than I ever could as a non-medically trained figure interested in this field. But of course, he reminded us, or he showed, that to reduce the burden of ill health, we need to shift the distribution of risk factors across the whole of the population. What greater risk factor is there to ill health than poverty? So a new settlement to tackle and alleviate poverty, to provide good, decent, well-paying jobs for those who can work, and respect and security for those who cannot work, has to be at the heart of building health security and wider prosperity and, building public health for the future. Thank you.
Thank you very much, Jonathan. Really interesting to hear your response to the Levelling Up paper and your thoughts on poverty and health. Just a quick follow-up question from me. In all of these issues around public health and poverty and relationships between things, this means that, as you know, the Minister of Health and the health portfolio is quite limited in terms of being able to tackle the issues that really impact on health. Do you have any thoughts about how you better engage cross-government, cross-ministries to really put health at the heart of a cross-sectoral approach?
Yes, so I was a strong advocate as the Shadow Health Secretary of a health in all policies approach, and strongly believe that we should aim to improve well-being, and I'm very attracted by measures around well-being as being a target for all government departments, as Chris was mentioning as well. In the past, I've talked about the UK, at a UK level, we should have a Wellbeing Act. We know the New Zealand government had a wellbeing budget. You are right that this is above and beyond just the responsibility of the Department of Health. And inevitably, the Department of Health will get sucked into questions around what is the right form of healthcare capacity. And there are inequalities in accessing healthcare as well, of course. You know, we talk about levelling up. Well, many of the areas that suffer some of the most pernicious inequities are the same areas that have seen public health grants cut. It's the same areas that have been disadvantaged by subtle changes in the funding formulas when health allocations are made. It's that these are the areas that are under-doctored when you look at general practice. And inevitably, the Department of Health will always get sucked into these questions about the capacity, your healthcare capacity. Yes, the debate around free at the point of use healthcare has been won and has been sustained for 70 years, but there are still debates about how you deliver that healthcare. But if you want to truly tackle those wider social and commercial determinants of ill health, that has to be a responsibility for the whole of government. It's a responsibility for somebody like me who aspires to be somebody to tackle and alleviate poverty and provide better work. But it's also a responsibility for those who are interested in regulation and regulations of business and so on. And one of the things that I'm worried about is the talk that some of the regulatory interventions the government were set to make around its anti-obesity drive look like they're going to be watered back because of the political dynamics in the Conservative Party at the moment. I would have said when I was aspiring to be the Secretary of State for Health that as somebody who was passionate about this, then the Secretary of State of Health would be the right person to grip it. Now I'm not in that role. Perhaps I would argue that you need it being gripped to the centre. In the past, people have suggested sort of cabinet office level committees or units and new units in Downing Street. In the end, my experience of working in government when I worked for Gordon Brown, and we put a big emphasis on child poverty. The reason child poverty became such a big emphasis for that government, over and above just the financial side, which the Treasury and the Department of Social Security, and then the work and pensions were focused on, it became a big issue for the Education Department, the Health Department, is because it was seen to be a priority of the two most powerful figures in that government, which was Gordon Brown and Tony Blair. So it has to come as a priority for the Prime Minister and the Chancellor, really, and that will drive change in government. I don't believe you have that under the current government, but I would feel confident that you'd have that should my colleagues form the next government.
No, and that's certainly seems to be the way around the world, that where you've got top level, presidential, prime ministerial leadership on an issue around health, then you get the buy-in. The structures themselves then follow, but you need the leadership from the very top. Okay, well, thank you, Jonathan. Again, I encourage people to be putting questions into the Q&A box so that we can come back to the panel discussion later. And I'm now I've been asked to then sort of shift from my chair role here into sort of stepping up to the, as it were, the virtual speakers lectern. As I do so, I'm mindful that we've been going for over an hour now, so I really encourage you all in the spirit of the healthy meetings to have a quick stand up and a stretch and a turn around as I try to wrestle control of the slides and see if I can work out how to use them. Bear with me while you're all stretching and turning around. And then let me see if I can move through this. So yeah. There we go. Yeah. Okay, so if you've all had a bit of a stretch and a bit of a stand up, I will now move on to my presentation. We've already had a quick introduction to the Global Climate and Health Alliance. We were founded in Durban in 2011 and are an alliance of health NGOs, health professional organisations and health and environment alliances from around the world. And we represent doctors, nurses, midwives, public health workers, health students, and other healthcare providers. And we elevate what we think is the trusted and influential voice of the health community to drive changes that protect and promote people's health by tackling the climate crisis through policy development and advocacy, research, and engagement. So my talk's bringing up the helicopter lens focus a bit further up from the UK and back to the global view again, because we believe that reimagining public health requires us to respond to the greatest challenges, both nationally and globally. And according to the WHO and the Lancet, the single biggest health threat facing humanity is climate change. The expert analysis of the evidence produced by the Intergovernmental Panel on Climate Change, the IPCC, in its 6th assessment report last year, is that increases in global temperature over 1 degree Celsius above pre-industrial levels, driven by human activity, has already occurred and has resulted in rapid and widespread changes to the climate. And unless there are deep reductions in CO2 and other greenhouse gas emissions in the coming decades, the targets of the Paris Agreement of the UN Framework Convention on Climate Change, the UNFCCC, for restricting temperature rises to well below 2 degrees Celsius will be exceeded during this century with catastrophic results. The report was described by the UN Secretary General as issuing a code red for humanity, and the climate crisis is a global one. It's not something that's only going to happen somewhere over there and that can be contained by strengthening border controls. So let me just spell out some of the key items in the health and climate change intersection. First of all, the impacts. Increasingly frequent extreme weather events, including heat waves, storms and floods, are taking the lives of thousands and disrupting the lives of millions more each year. And it's impacting on healthcare facilities, amongst other parts of our societal infrastructure. Last year alone, major climate change related health disasters occurred in China, in India, Pakistan, Vietnam, Canada, Germany and Belgium, and many other nations. Food systems are increasingly disrupted by extreme weather, which is exacerbating food insecurity, hunger and malnutrition. Rising sea levels are destroying homes and livelihoods, which are critical to supporting people's health. And as global temperatures increase, the risk and spread of vector-borne infectious diseases increases. And as we intrude into ecosystems, notably with intensive agriculture, the risk of zoonotic diseases increases. Climate change impacts are also taking a serious toll on people's mental health, causing post-traumatic stress disorders and anxiety and worsening existing conditions. Oops. So there are also common drivers to the climate crisis and of non-communicable diseases, notably around air pollution, most significantly from burning fossil fuels, is causing more than 7 million premature deaths each year. And that's the equivalent to 13 deaths every minute. On the other side of the coin, there are co-benefits of reducing climate impacts on reducing healthcare and related socioeconomic costs from catastrophic events, the viral diseases, and NCDs. And the health sector itself can make a significant contribution to carbon neutrality targets. Health institutions are responsible for 4% of global greenhouse gases emissions. They're a major part of our economy. And if the health sector is committed to the value of do no harm, we and it must take this seriously, both in terms of addressing our own impact and in showing leadership in achieving the scale of change demanded by the crisis. So, and we have shown that leadership in the build-up to the last Global Climate Summit. The COP26 was hosted by the UK and held in Glasgow last November. There was a crescendo of health sector voices making the strong arguments for climate action. And I'm going to call out 3 initiatives in particular that make the case far better than I can in these few short minutes. And I've also borrowed from all 3 of them in this presentation. At the beginning of September last year, the UK Health Alliance on Climate Change led an unprecedented intervention that saw over 220 medical journals around the world publish the same editorial calling out the climate crisis as a health emergency. It was timed just ahead of the UN General Assembly, which was seen as a crucial moment to urge all countries to deliver enhanced and ambitious climate plans. And the editorial made points that health is already being harmed by the environmental crisis, with harms disproportionately falling on those countries and communities that have contributed the least to the problem and are least able to mitigate the impacts. The emergency action is needed to transform societies and economies, and governments must act to intervene to support and redesign transport systems, cities, production and distribution of food, markets for financial investment, health systems, and much more. The transversal approach that David was talking about earlier in the context of the pandemic. And such a transformation would realise vast health benefits. Oops. The WHO produced its own special report for COP26, calling for health and social equity to be at the heart of the critically needed urgent climate action. It seeks a commitment to a healthy, green and just recovery from COVID-19 and for a transition to what it calls a well-being economy. The chapters of the report cover a range of systems, including energy, food, transport and urban environment, as well as highlighting the interdependence of human health and nature. So this could be seen as WHO's own post-pandemic manifesto for a new vision for public health. And following on from the extraordinary achievement of the Health Journal's editorial, a healthy climate prescription was developed by a group of international and national health organisations as a vehicle for the global health community to raise its voice in the climate crisis. It was launched alongside the WHO report in a joint press conference in October, and it recognises the health professionals' ethical responsibility to speak out about this greatest health crisis that we face. It also made the health case for strong and rapid climate action to keep alive the ambition of restricting global temperature rises to 1.5 degrees Celsius and putting health equity at the heart of climate action. It was signed by over 600 health organisations representing around 46 million health workers. That's about 2/3 of the global health workforce, and was delivered by hand by 30 plus children's health care workers, including Great Ormond Street's chief exec, who cycled 500 miles from London. And it was handed over, handed over to ministerial representatives of the current COP presidency, which is the UK, and the next COP presidency, which is Egypt, and remains our manifesto for health and climate action. So you can still sign the prescription and share the 2-minute video that we showed at the COP, so you can see there. Okay. So I just want to, seeing as we're talking about developing a new vision for health, I also want to flag 3 aspects of health and climate that really feel relevant, along with some useful resources. Firstly, for a really good overview of health in the global environment agenda, covering the whole range of agreements and treaties, I really commend to you this International Institute for Sustainable Development report that came out a couple of weeks ago in January, which lays down the challenge to the health sector to use not only the megaphone for campaigning for climate action, but also what they call the microphone for lobbying and advocating for integration of health into environmental policy, law and governance. And one such consideration that they bring up for adopting this approach is a rights-based approach. In 2015, the right to health was recognised in the UNFCCC Paris Agreement as one of the contexts for the agreement, and the right to health was again recognised in the 2021 Glasgow Climate Pact, reflecting that the environment we live in is inextricably linked to our health. And this has been made even more explicit in the UN Human Rights Council resolution adopted last October that recognises the human right to a safe, clean, healthy and sustainable environment. And the UNHRC has appointed a new special rapporteur on the promotion and protection of human rights who will follow and track progress on climate change and equity across the UN. The adoption of the right to a healthy environment opens up new opportunities for making the connection between health and environmental policy, regulation and international law, and is a step forward in advancing the Sustainable Development Goals and building common agendas. Another key point for developing a new vision for public health is understanding and promoting the co-benefits of climate action. Averting the truly catastrophic impacts of a temperature rise of 2 degrees Celsius or more requires taking a level of ambitious and rapid action this decade that most of us will find challenging, as it will require us all to change and reduce consumption, and that risks being unpopular, which is of course anathema to most politicians. The key point here, though, is that health benefits from implementing ambitious climate action far outweigh the costs. The health benefits are the sugar that could sweeten this pill. There's a large body of evidence now showing that climate action aligned with Paris Agreement targets would save millions of lives due to improvements in air quality, diet and physical activity, along with other benefits. A commitment to a real phase out of fossil fuels will reap true health benefits, notably by reducing air pollution, which is of course a key aspect of the health inequalities experienced in the UK. And these health benefits will not be delivered by an over-reliance on offsetting projections via carbon capture mechanisms existing and yet to be developed. There are tools available to support policymakers to calculate these health benefits, such as a Carbon H tool. And just a quick plug for GCHA's own Healthy NDC scorecard that provides a tool for holding governments to account for integrating health into their nationally determined commitments to the Paris Agreement. Okay, so let me just go up again. Sorry, I've got David's problem now. I need to go back. There we go. So one of Chris's book's chapters, and one he talked about just now, cries out for a new positive vision for the NHS. So I want to draw attention to what feels like at least one beacon of hope. The NHS England has developed its own vision and is showing global leadership in its Green NHS initiative. Thank you. It's the first health service in the world that has committed to achieving net zero emissions by 2040 and is led by their own Chief Sustainability Officer, Nick Watts. And its contribution is not only in setting out to cut its own impact, but also in engaging staff and the community they serve, showing that the change can happen and hopefully shifting attitudes that will build the support we need for climate action. So I hope this has been a very quick taster of the health and climate nexus, and I hope it gives you some inspiration to engage with building the change that's needed to avert the climate crisis, and that you'll take away the key messages that the health benefits far outweigh the cost of climate action, and that the health sector can make its own significant contribution, both by tackling its own impact contribution to net zero, and by showing leadership in making the changes we have to make. So I'm now going to try and step away from the lectern again. Yeah, it's very tricky. I hope you'll bear with me, and apologies for some of the errors on the clicking. But I hope that sort of gives you that overview of health and climate. Again, encourage you to put questions on that into the Q&A. And I'm going to move on to our final speaker. So Jyoti Nabarro is the Director of Policy and Public Affairs at RSPH. In previous roles, she's established and led the Cancer Policy Research Centre at Cancer Research UK, where of course we work together, and was a consultant at the World Health Organization for non-communicable diseases. She has experience in influencing evidence-based policy and practice change in health, including paediatric care pathways. And I think what Jason's going to try and do is talk about public health in the UK currently and what gaps there are and where do we want to be by 2045. So over to you, Jason.
Thank you, Alison. And thank you all for joining us today. We have a truly international audience and such great interest in the event, which really proves that the need for this conversation is now. I also want to thank my panelists fellow panelists for the time they've given up, and of course the author and the catalyst for this event, Chris Thomas, and for his book 5 Health Frontiers. Our aim as the RSPH in hosting this event is really to galvanise the conversation, to look at what we want to see and how we want to see this change across the public health landscape, and how can we achieve this change in order to have a radical plan that will actually benefit all of our public's health. And if we really don't have this conversation now, then when can we have it amidst the largest global public health crisis that we've ever faced? So, if I just... This is the time when we have had the largest spotlight shine on public health. In the past, the media has talked about health when they talk about health services, the crisis within the NHS, and how to solve ill health is all about putting money into the NHS or putting a plaster on something there. Very rarely have we seen stories about public health that talk about measurements to improve health, prevent illness, or reduce health inequalities. The pandemic has shone a light on all of these areas. Never before have we seen such interest in how a person's lifestyle could actually impact their quality of life and the impact of disease. We were told that the disease would be a leveler and it has no preferences, but actually what we have seen through COVID is that those from the more deprived communities are more heavily hit. What we really need to understand from this is that before the pandemic, the public's health across the UK was not in great shape. And what we have really seen is how the pandemic and how a virus such as COVID can really run through the country and exacerbate the problems that currently exist. As I've said, COVID has been a crisis that has exposed and exacerbated our societal challenges, and it's the societal challenges that pose the greatest threat to our public's health. We know for a long time that those in more deprived communities suffer worse health outcomes than those from the less deprived communities. Children from more deprived communities are more likely to become obese. In fact, they're 2 times more likely to be more obese than those from the less deprived communities. Children who are obese become obese adults. And we have seen during COVID the link between obesity and the disease. We saw in June 2020 that 8% of those patients that were in ICU and critical care were actually more obese, and therefore affecting those in more deprived communities. We have seen how environments that actually lead to unhealthy behaviours impact those in more deprived communities, be that the obesogenic environment, be that those that lead to increased alcohol or drug use, or even tobacco use. In 2020, we saw the highest number of deaths from alcohol-related or drug-related incidences, highest amounts since records began. And this again impacted those more deprived communities than less deprived communities. We have seen that the overall death toll from COVID continues to be higher in those from more deprived communities. Throughout the pandemic, we've seen the impact on our ethnic groups. We have seen that in the BAME communities, there were 4.2 times more likely to die from COVID than those from other groups. We've also seen how woefully poor our data collection is in these areas. Without surveillance and without strong data collection, we really don't have the cornerstones that we need to support our public health. Life expectancy is something that's constantly talked about. We know across the UK that there's strong disparity amongst the life expectancy and the healthy life expectancy that people are expected to live. 20 years difference between those from more deprived communities to those from less deprived communities. And life expectancy is only reduced through the pandemic. All of these factors have actually grown the inequalities and the inequities we face in health across the public health system. We need to do more to ensure that we have better public health and better public health services to support our growing population and to actually support the wider society needs. But our public health systems are under-resourced and overstretched, and this was even before the pandemic. Services had staffing levels way below benchmarks, even in public health. We've already talked about how there's been year-on-year disinvestment in public health between 2015-16 to the current date, resulting in a 24% per capita decrease in public health investment. We've seen older people requiring not receiving the help that they need, and the increase in number of people who need this help. And we also know that with the backlog of health services that have occurred as a result of the pandemic, public health needs to be able to step up to support this. Overall, we need increased and longer term investment in our public health landscape. But what does this look like, and what does this mean? We should never let a serious crisis go to waste, and this is our opportunity to do things that we think we could not have done before. That's what Rahm Emanuel said, Barack Obama's chief of staff, and truly this is our opportunity. We have a position right now where the public has never before been more engaged with what public health means. They have a greater understanding that if all of us are well, then we are well. If none of us are well, if any of our communities are unwell, then we are not well. This is seen in the vaccine rollout. We're all safe when everybody is safe. And therefore, how can we build on these messages? How can we build on these learnings and actually take the opportunity to make sure that we build back better and build back for the future? And what do we want to see from this? In 20 years' time, don't we want to see a world where health inequity has reduced, where we have healthy life expectancy that's equitable across all parts of the nation? Don't we want to see a world where we've managed to eradicate smoking-related diseases, where we've managed to eliminate diseases such as HPV because everybody's had access to the vaccine? Don't we want to see a future where every child born has the same prospects and the same access to healthcare? But what will this take? If we truly want to level up in the UK, and we've talked a lot about this yesterday and how we've had a new white paper come out, then we really need to look at what the strategy is and what can we actually do and what can we tangibly change to make it better for all members of society. We need to improve the quality of life and life expectancy for everyone. And this is not just fixing small intermittent areas of care. This is about looking at across all areas, societal and health, that can actually improve this. We need to create healthier environments that support healthy life and support those making those choices to make healthier choices. We need to have health equity across all demographics, and we need to have greater investment in public health. We keep coming back to greater investment in public health, and when we talk about it, we need to think about what this looks like. What do we mean by this, and what do we want from greater investment in public health? It's important that we get this right, that we don't just take the money and we don't just take the money and plow it into something that won't give us what we need. We need to think locally, we need to think nationally, we need to think internationally when we think about public health, and we need to think about all our societies. What can this be, and how can we start this, and what is the roadmap that we need for public health is something that I wish we could start discussion on today. So what next? I've talked to you about the issues that we have. We've heard about the possible policy levers we've had. We've heard about the global issues, and we've heard about five frontiers that we need to tackle. But what we want today is to start the conversation. We want you to put your views across and hopefully ask the questions that we need to have answered in public health. What needs to change and how do we change it? We want to continue the conversation. We don't want this to be the end. We're hoping to build on this, and we've already sent invitations out for a round table where we hope to engage leading medical practitioners and public health practitioners from across the 4 devolved nations, and also our own in England, OHID and UXA groups in the government. We need to develop a plan for change. We need to develop something that's systematic. We need to develop something that's a roadmap. We need to develop something that we can campaign for and that we can talk about in all fora. We need to have joint action. We need to stop the cacophony of public health sound and make sure that we speak in one voice, that we need better investment and better public health landscape for all our societies in order to prevent the next pandemic being as bad as it was this time. And we need the right investment. We need to build on the learnings that we have and really make sure that we're looking for radical change that will be long lasting, and change that will make sure that the next time a pandemic decides to come our way, we're better prepared and we don't have the death tolls that we had this time. So thank you. I'm going to leave it there and really open up the floor for questions. If you'd like to contact us and talk to us more about this, please do. Myself and the team are really happy to hear your views.
That's great, Jyotsna. It's really inspiring to hear you from RSPH really be taking this sort of leadership in trying to engage in this conversation and get people talking. And the question I'd like to put to the rest of the panel really is, given everything we know, how the pandemic has, dominated our lives for the last 2 years, we've heard so much about the inequalities in the experience of the pandemic and its outcomes over the last couple of years. What do you think it's going to take to capture the public's imagination to really understand these underlying issues and much more fundamental needs for change around public health, addressing these social determinants, the economic determinants and so on, get beyond the questions about the masks and the vaccines and get to really engage the public in talking about what's needed to change public health? Well, Chris, maybe I'm sure you've given that a lot of thought.
Thanks. I think there's two things really that need to change, in terms of, maybe three, in terms of kind of that conduit to the public, because we're having a great conversation amongst those that want to have that conversation, but it's the public and people who will drive the kind of change that we're talking about. And if it's going to be bold, it's going to take a lot of people. So I think one is the language we use. I think sometimes we talk about health in a very different way to how others in kind of progressive movements talk about their issues. We talk about, sometimes in quite a technocratic way, the social determinants of health. Others talk about justice. They talk about inequality. And I think the more that we can talk about injustice in plain language is going to be the better, and stronger and more attractive our campaigns are. I think there's something about how totemic the policy is. So again, the campaigns that came out of the last crisis, the financial crash, that were the most powerful for me, talked about how society works overall. It was the Green New Deal from the climate movement. It was the new economy thinking that came out after that as well. So I think the more that we can reach out and talk about kind of how society works, rather than more siloed asks, individual determinants, that kind of thing, the better that will be. And the last thing is, I think, when research looks at what does it take for movements to succeed, one of the results is often, this sometimes surprises people, is that the kind of strength of activists and rebels within that, those that can show the burning platform to people, are really important. We don't have people stopping traffic in the way that an Extinction Rebellion or others do for the social determinants themselves. So there's a big question for us about how we go out and kind of not endorsing those methods necessarily, but take that as a symptom that maybe the things we're saying don't feel burning enough and don't feel compelling enough to enough people.
Thanks, Chris. Jonathan, any thoughts for you, how you would capture the public's imagination?
Yeah, this is a really, really great question, and it's something I've explored. And obviously, we're in a different era. It's the 21st century. The parallels are not exact, quite obviously. But there is a reason why the 1945 moment around the welfare state in the United Kingdom came in 1945 and didn't come in 1919 or 1920 after the Spanish flu or the influenza pandemic. And it is remarkable when you think about our collective history and our national psyche, how much we quite rightly remember what we lost and who we lost in war, and we quite rightly celebrate, particularly if you're of a more progressive minded, but generally most people celebrate the welfare state that was created in 1945 and consider it a great moment and a moment to be very proud of, particularly around the NHS, but other elements of it as well. But it's striking how, until this pandemic came along, how little the experience of the impact of Spanish flu pandemic was part of our national conversation, was part of our public policy conversation, was part of our historical conversation. We never talked about it. We rightly talk about whether there should be monuments, commemorations for those who've lost their lives, quite rightly. There's no monument or commemoration for those that we lost to Spanish flu. Now, the point, the reason I'm making this point is not just to sort of draw, sort of, isn't that an historical curiosity? The reason I make this point is that I remember early on in this pandemic, people were saying this will lead to another 1945 moment. And I think the point is that, and you see this to a certain extent now with public opinion, once you've been through such an awful pandemic where you've made awful sacrifices, and you're obviously, and people are quite rightly angry with the behaviours of our national leaders and rules they broke and all that kind of stuff. I think there's a psychological sense in which people want to move on quickly and don't want to be keep getting reminded of some of the awfulness of the sacrifices we all had to make. So that's the first thing. So but the pandemic has quite obviously brought into sharp focus deep-rooted problems in society. It has brought into sharp focus inequality, poverty, widening inequalities in educational attainment. It's brought into sharp focus the issues around work and health and exposure to illness when you have no option to be exposed to a virus circulating because of the nature of your work, and so on. And I think it comes to sort of Chris's point. How do you build a mass campaign on these issues? Because typically in health world, the campaigns, and this is no disrespect to those passionate campaigners out there, some of them who may well be watching us on this Zoom, as Chris said, is in some ways is quite conservative. It's trying to conserve current healthcare capacity rather than a bigger campaign around health inequalities. But I think we need to link up to campaigns around poverty and inequality. I think we need to link up to the climate change campaign because, as you were saying, Alison, climate change, biodiversity loss, these will be drivers of future pandemics or dangerous infectious disease outbreaks in different parts of the world, which will impact us. So we need to link up to these wider campaigns. But in the end, I think you've got to make this about, I believe, the impact of inequality. Because if you believe, as I do, and if you take the sort of, as I say, that sort of Geoffrey Rose approach to public health, that the way in which you decrease the burden of ill health is by shifting the distribution and increasing population health overall, as distinct to just targeting those who are ill with, new medicines, antivirals, therapies, whether that's genomics or, wearables, all important stuff, by the way. It's not binary, it's not an either or, but I still think in the end, you have to shift the overall distribution. And that means a bigger population health approach. And if population health is determined by poverty and inequality and increasingly climate change, then we have to link up with those campaigns.
Yeah, thank you. And personally, in the work that I'm doing now with the Global Climate and Health Alliance, I do, as I said in the presentation, feel really strongly that there's an upside to this. That the climate change is an incredibly real and imminent threat to us and the planet and our country. And yet there's such a positive to taking the steps that we need to take that will help public health. So you're bringing these two things together, like I say, is the sugar that should sweeten the pill. So I really feel like, we all know that, every time there's a traffic controls, low emission zones, people are all up in arms. But if you focus in on what that means in terms of health and protecting children from air pollution, it's very hard to argue with that. So I think, bringing these two things together are so important. I'm going to move on to another question in the Q&A box, but it's very related. James Clark Wright says, he sort of draws attention to the problem that the NHS, as you do, has been largely a reactive service to ensure universal access. But to be a true health service, it needs to evolve and be more proactive and focused on prevention. So do you feel like he asked if we feel like the pandemic will be enough of a catalyst to usher in a change in focus? So, as it stands, the NHS is struggling to deliver treatment. How can we enable the NHS, or what role do we see as the NHS in delivering prevention? Any thoughts on that?
I think,
Chris, or Jason, go ahead.
I think just briefly before I hand over to Chris, the one thing we do know is that it is the only prevention of ill health that will support our NHS to become more sustainable. And we therefore do need to focus on what does that mean and what does that look like. And that does mean tackling poverty, that does mean tackling climate and health link. And it is only through those things that the NHS will be more sustainable and being able to serve us for another 70 years. I'm going to hand over to Chris to answer more of those details.
Thanks. I think there was a week that really summed up the problem to me last year, which was the week where the Health and Social Care Levy was announced. And 7 days before that, you see uplift for families was reduced £20, and obviously we now know we're in a cost of living crisis. And what was really kind of remarkable about that is that's an act that we know from the evidence that pens up demand for the NHS, whether that's in a year or whether that's in 10 years, whether that's in 50 years. We know that that has, through the life course, a negative impact. And so we're heaping pressure onto the National Health Service because that lack of prevention, kind of as a cross-government priority, let alone as an NHS priority, isn't embedded. So I think until we kind of move away from that mentality, and this is why I talk a lot about expanding that really popular cross-party, free at the point of delivery based on need mentality to public health before diagnosis. But until we get there, I don't think we'll have much luck. I think prevention in the NHS is it's fundamentally the way to sustainability, but it's incredibly difficult when you have a system that's run as hot as it is, because it's very hard then to, one, change strategy, but two, to do some of the things that feel like nice to haves. So I think there's a kind of preceding step to that, which is the transition from top of its capacity to top of its game, and a recognition that actually running the NHS in a way that isn't pushed to breaking point can be cheaper, can be, in fact, almost definitely is cheaper, better for people's health, better for the economy, all that stuff as well. So yeah, some thoughts there from me.
Thanks.
Yeah, I mean, we most certainly have to get better at prevention. At what stage? I mean, there are the wider determinants that we need to deal with, which is the issues, which is now my focus in my new brief at Work and Pensions, poverty, and the wider social and commercial determinants. Not spoke much about housing in this debate. Housing is also a huge determinant of ill health. That is a responsibility for wider government, local government, but also other institutions in society as well. And then, of course, there is the prevention work that the NHS in itself can get better at. I mean, this is pre-pandemic, and Chris might be able to correct me, but I don't think updated figures have been released post-pandemic. But certainly going into pandemic, I think only around 50% of those over 40 were going for their regular health checkups for hypertension and so on with their GP. If you want to get better at prevention, we've got to get better at delivering access to general practice, and that is about health inequalities as well, because Tudor Hart's old warning about the inverse care law, that is writ large again. We have gone backwards on access to general practice in poorer areas. I mean, we're hugely under-doctored in poorer areas. We need to fix that if we want to get better at prevention, of course. And then there's all the exciting stuff, which the newspapers get very excited about, all the advances in genomics and so on, which will be, that will all be great. We should explore all that. We should invest in all that modern technology. I've been looking into it and learning some more about it in part of this research fellowship I do at Cambridge. It is great, but in the end, I still believe you have to improve the population health overall, and that's a multifaceted approach. That cannot be just the responsibility of the National Health Service. It's not possible for it just to be the health responsibility of the National Health Service.
Thank you. So I got another question. It's another really big one from Alan Higgins. He says national economies were deliberately changed to respond to the pandemic. How can we build on that to move to respond to other public health challenges that are tied to how the economy is run? Certainly, having worked on issues like tobacco and junk food, where it's the interests of the business sector were held as such a barrier to prosecute a public health interest, it was amazing to me to see what happened when the pandemic hit and the extent to which we were willing to restrict the economy in order to save lives and protect the NHS. Beyond the crisis of the pandemic, do you think anything shifted in terms of that power balance between protecting public health and corporate interest?
I mean, if I just jump in quickly, we've got to do something around wages, low pay, and hours worked. One of the problems of our economy is that increasing numbers of people who are in work are in such low paid jobs that they're in poverty. We need to resolve that. We need to fix that. We need to intervene to resolve that. A second issue is just to be aware, I think, although this is my hunch, I've not got any sort of data to back it up. If living or learning to live with COVID means that we have to accept a degree of COVID continues to circulate, that inevitably means more exposure to COVID as we go about our working lives, which inevitably means more people getting sick from COVID. Hopefully vaccination reduces the severity of sickness, but it would presumably mean a number of people spending chunks of 5 days off work every year, more so than they would in the past. That's going to have an impact on productivity in the economy. So as I say, I haven't got any data to back that up, but that's my hunch. If living with COVID means accepting a degree of the virus circulating and us sort of just taking it on the chin, as Boris Johnson suggested we ought to do right at the start of this. But I think you've got to deal with wages and the fact that the economy at the moment, yes, where it creates jobs, it's almost like a U bend or it's creating low paid jobs which are not too many low paid jobs, while lots of high skilled, well paid jobs. So there's not enough jobs being created that people can build a life, maintain a family, run a home on. We've got to fix that in our economy.
Great. Just to say, there was a couple of polls that the RSPH wanted to run with this audience, things we've got them, and I think, have they been launched and ready to go? I think if you see them on your screen, please do respond. We're just using the opportunity of having you all here to just get that feedback. Jokes, do you want to say anything to that?
I was just going to say the first question's gone up, and it's just asking to what extent do we agree with the statement that the UK is now more prepared to quickly and effectively respond to future pandemics compared to pre-COVID times. And we're really hoping that this data will just give us an indication of where all of our public health colleagues are sitting and thinking about the future.
Okay, and I believe there's going to be a second one coming up shortly as well before the end of the discussion. So yeah, we were just talking about the economy and public health and the impact of the pandemic in terms of wages and so on, and that piece. Chris, Jokes, anything you want to add to that before we close?
I think there are key things that have happened during the pandemic that we would not want to lose. I think the way we've managed to mobilise the public understanding and their engagement with public health and their understanding is critical. And the RSPH is committed to providing strong and high quality information to everybody to support them in that. But also, moreover, the way that we've managed to galvanise the wider public health workforce and the way they've actually really engaged with vaccinations and with helping the rollout, with helping across all areas, be it supplying food, be it helping their neighbours. I think we've really learned that we can't be alone and isolated in the way that we live as we move forward. We are communities that need to work together. How we harness that and how we build on that moving forward and actually truly value the wider public health workforce as well. And as Jonathan's talked about, ensuring that they're recompensated in the way that's suitable is something that we really need to think about and look to answer, and not least in our social care area. Our social care workers have really been on the front line, and how can we recognise that, and how can we show and recognise their importance in our society and our healthcare system?
Brilliant. Okay, so I'm really conscious of time. I can see the second and last poll has gone up, so please do respond to that. While you're doing that, I just wanted to check, well, first of all, to thank you all for joining us today and being part of this conversation. It's been really wide-ranging. There's been a lot in here to discuss, and I hope this is just the beginning of a conversation, and I'm very pleased to hear the Jokes are sort of setting up yet more conversations and another roundtable, which I think would be so useful. As I said, there is so much here to discuss, so huge thanks to Jonathan for all his time today and bringing his perspective, because I know he's worked on these issues for so long, really helpful. And to Chris, and just a reminder that as his publishers are offering a discount to people who have been on this discussion. So you can use the discount code, which I think has been in the chat, but is it RSPH40 if you want to get a copy? It is of Chris's book, and I really commend it to you. It's a fascinating read. Thanks also to David, who joined us earlier, for his overview of the pandemic, both bringing out the need for focus on local services and the need for cross-sectoral leadership. And we will hopefully see you all again at another event such as this, and that we try and build the dialogue and build the engagement about the need for a real change on public health. So thank you all very much.